It's July the 12th. This is your Sunday Synthesis podcast with me, Howard Feldman, in conversation with frontline COVID expert, Dr. Anton Meyberg. Numbers are rising fast according to the Minister of Health, Dr. Zweli Mkhize. This is to be expected. We are in the eye of the storm. We are fast hitting the surge, which, according to the Minister, should last for July and August. I don't need to tell that to Dr. Anton Meyberg. I know that he hasn't been home for many hours, having spent the night sleeping on a couch in his office, simply because it wasn't worth it. It can't be easy. You are on the front lines. You are in the trenches. The imagery is all there. But why don't you tell us what you are seeing at the moment? Good morning.
Good morning, everybody. So currently we're sitting on 12,856,364 cases worldwide, with 567,914 deaths and 7.4 million cases recovered. South Africa has now moved up into 10th position for the number of cases, with 264,184 cases and 3,971 deaths. We're currently averaging about 11 to 13,000 new cases every day. There are 93,044 cases in Gauteng at present, with 3,108 in hospital, 330 in ICU, and 187 ventilated cases in Gauteng. Currently, the hospitals are overfull. They are brimming over. All the wards are filling up with COVID cases. Multiple admissions are coming in. The majority of the admissions are all COVID cases. And of the COVID cases coming in, the majority of cases are people with extreme comorbidities. More than one comorbidity, 2 to 3 comorbidities, sick patients, very ill people who need to be on oxygen and other medication.
Right, so we're going to start looking, we're going to go through many of the questions that people have. Again, I want to thank everybody. We had pages upon pages upon pages of questions. As we did last week, I tried to group them into areas. I do apologize if I don't get to yours, but we really do try to answer everybody's questions. And we're going to move through them as quickly as possible, considering the volume of questions that we are receiving. So the first one, and one that certainly bothers me, is the comment that has been made about hospitals running out of space, and more concerningly, hospitals running out of oxygen. Can you explain why this is the case, and how we didn't anticipate during the lockdown and during the flattening of the curve that we would need this amount of oxygen?
So I think that people got to understand that every hospital in Gauteng in the country gets a certain amount of oxygen delivered to them. There's big oxygen companies, such as companies like Afrox and other huge oxygen companies, that generate a certain amount of oxygen that can be used in hospitals. A hospital gets a certain amount of oxygen that generally lasts for 3 days. Because of the immense amount of oxygen needed in every hospital, the suppliers are running out of oxygen, not the actual hospitals, but the suppliers who supply the hospitals are not able to keep up with the demand of oxygen necessary. What's happening is that, first of all, more patients are going on oxygen, and then the sicker patients, the ones who are in ICU, are going onto a modality of ventilation called high-flow oxygen. Now, this is not a ventilator, but this is something where we give 60 liters of oxygen at 100% delivery rate. So you're giving a much higher proportion of oxygen needed to patients in the hospital, and they just cannot cope with the supply-demand issue at the moment. So as I say, it's not a hospital issue, it's a supply issue from the suppliers.
Is this a concern for you, or do you think that we'll get this under control?
So it is a very big concern, because if you don't have oxygen, you can't ventilate people. But I do believe they are working on ways and measures to try and get this under control. Look, we still haven't heard about Nasrec yet, but as far as I know, Nasrec still doesn't have oxygen for patients. So I'm not quite sure what the purpose of having a field hospital is without oxygen, but hopefully they'll get their act into shape.
So, and is there a real need in Gauteng? We saw in the Cape, they opened a field hospital at the Cape Town Convention Centre. That was it was very, very useful. Do you see the need, as far as you're concerned, for Nasrec to open?
There's no doubt in my mind we need these field hospitals to open. Okay, with what we're seeing now, we're in the eye of the storm. We're not apparently at the peak of the storm, but I've got a very jaded view. You know, if you look at an in-hospital point of view, we're peaking. There's no doubt about it. out of hospital, we're definitely not peaking. So from that point of view, we need field hospitals, because some of the sicker patients can be managed in a field hospital with low amounts of oxygen. That would help take the strain off the hospitals and would enable hospitals to have other beds for the sicker patients. So these things are very necessary. And once they are up and running and they will run well, there will be a big relief to all the hospitals throughout the country.
One of the biggest issues that everybody is asking us this week, and certainly it came to the fore this week, is the statement, I think it was by the World Health Organization, or certainly a number of scientists that approached the World Health Organization, saying that the virus is potentially airborne. Can you please firstly give us the distinction between an airborne or a droplet-borne virus in terms of spread, and the impact that this could potentially have on how we manage our prevention?
So I think everyone's got to understand something about the World Health Organization. The World Health Organization is a group of people that are collected together that have to have meeting upon meeting before they can come out with a collaboration and a decision on something. So we can't wait for the World Health Organization to give us answers. What we do know is a group of about 200 to 300 scientists all met together, and they have, through their means, decided that this is an airborne virus. Now, we've got to look at the epidemiological studies, we've got to look at all the studies and see what's going on around us. And you've got to compare people who are getting sick to people who are not getting sick. If you look at people who've come from overseas in airplanes, if it's an airborne virus, as we say, then how come everybody who's come on an airplane who wasn't wearing a mask and there was one infected person on the plane, how come they didn't get sick from the virus? So there's lots of sort of things that we need to try and work out in our own minds as scientists, as doctors, as epidemiologists, as people, to understand how much of this is relevant and how much of it is true. What they're basing their study on is a bunch of people who are at a choir practice, for instance, or in restaurants or in eating places where there was a high load of people in a small contained area, not wearing masks, singing and expelling air, and they're calling on that basis an airborne virus. Remember, an airborne virus is something like tuberculosis or measles. Those are the ones that are extremely airborne, okay? Respiratory viruses spread like that, and we've got to be very careful because those stay in the air for a number of hours. A droplet virus, something like we still believe COVID-19 is the droplet drops to the ground and doesn't stay in the air for a number of seconds, and that's why it's safe to wear your masks, etc., and that type of protective mechanism. But this is a novel virus. We know things change on a day-to-day basis. We will find out in a week, in a month, in 2 months, a completely different mechanism of how this virus works. What's important for now? You have to wear a mask. Both people who are in contact with each other, they have to social distance more than 1.5 meters from each other. They have to observe hand hygiene. That way, you are protecting yourself. For healthcare workers, more importantly, have to wear visors and N95 masks when they are in exposure to an aerosol, someone who's coughing directly into their face who's not wearing a mask. And in that case, it's far more important to be more protected. So at this point in time, we're telling people, carry on with your masks, carry on with your gloves or your hand washing procedures. You don't have to go out wearing a visor as of yet, but that might change down the line. But at this point in time, we're not seeing the spread through that mechanism.
So are you still comfortable, people, let's say, walking outside with their masks on, provided they do have their masks on? Obviously, driving somewhere with the window open, because it's
look, if it's the way you're describing it, if you're driving in your car with the window open and you get the virus, then we should all by now have had the virus and all been sick and all been in hospital. So we know it's not like that. And as I say, with preventive measures and social distancing, we can keep this virus at bay.
Okay, so your view at this point is continue treating it as well, the reality is your view is it's irrelevant, because as long as you're wearing your mask and as long as you're wearing your mask
and your hygiene and your social and public distancing, that's what's important for now. As I say, down the line, we might add extra things, but at this point, it's not necessary and hasn't been deemed necessary anywhere in the world.
Okay, so that's an important one. There are a couple of things as well that are coming up. Things like reports talking about long-term damage once somebody has suffered from COVID. Obviously, within the South African context, it's probably too early to tell this, because we're only starting to see recoveries round about now. But what are you seeing around the world in terms of long-term effects or medium-term, because there's no such thing as long-term at this point?
Our biggest issue are people who are in ICU on ventilators. Those are the people who we're seeing the major sequelae, which is the major consequences of the disease. Someone who's been on a ventilator, who's developed acute respiratory distress syndrome, who's got bilateral pacifications of their lungs on CAT scans, who's not able to breathe for themselves, those people do tend to have lung damage. Whether it's acute or chronic, it's too early to tell. An acute disease is something that's for less than 6 months. Chronic is more than 6 months. We are only 6 months into this disease, so we cannot tell if the long-term ramifications of this virus will be more than 6 months or not. There are certain people that have neurological as well as psychiatric delays or developmental problems due to this virus. In other words, a lot of people can suffer from headaches. And it's a very important point. A lot of people get anosmia, which is loss of smell, or ageusia, loss of taste, okay? And that's because the olfactory nerve and some of the cranial nerves are affected. We still don't know how long it will last for, but in the majority of cases, more than 90% of the cases, that does dissipate. It may last for a month, it may last for 2 or 3 months post-COVID, but the majority of cases does dissipate and does go away.
A lot of questions around that coming from people. And that's, of course, what's so interesting about the questions and about your questions that you've sent us, is that we can see the shift. Now we're starting to see so many people asking us questions about their own health, considering that they have COVID and are going through this process. You mentioned the other night on another podcast that you were on, actually a webinar, about the different stages of the disease. I found that really fascinating. Will you take our viewers through that, please?
So there's 3 developmental stages of the disease. There's the first stage, which we call the respiratory phase, which has got a small amount of respiratory affectation, the cough, the mild shortness of breath, the loss of taste, the fever. The second phase is what we call the pneumonic phase, where it progresses into your lungs and you get a COVID pneumonia, which is a viral pneumonia, where you get ground glass opacification on a CAT scan, or you get a bilateral infiltrate on your chest x-ray. And the third stage is the hyperinflammatory stage, where you get your cytokine storm. And those patients tend to be much iller. And that's the smaller amount of people that we're talking about, a 5% of the population that are critically ill. And those type of people land up in ICU, necessitating going on to intravenous corticosteroids, on interleukin-6 inhibitors. Things like remdesivir is necessary for them, and some of those patients need to be intubated. And those are the 3 basic cases. The majority of cases we see are the respiratory phase and a crossover between the respiratory and the pneumonic phase. And of those who get the early pneumonia, it's not severe. So the ones we worry about are the pneumonia transitioning into the hyperinflammatory stage.
Are we seeing the virus behave any differently in South Africa to anywhere around the world? Or is there a specific South African slant because of the way we live our lives, because of TB, because of HIV, because of whatever?
So we haven't seen a major difference between HIV or TB in our patients. If I'm looking at the cohort I'm seeing in hospital at the moment, I'd say maybe 10% of the patients who have got COVID have got immune suppression from TB or HIV, which is a very small amount. The problem we're facing in this country is the dense populations in areas like Alex, where you've got a high population amount of people, more so than in the slums in Brazil, and these people are getting affected, and these people don't have the ability to social distance. There's multiple people staying in houses together. They cannot quarantine, they can't isolate, they're going on public transport, they're not wearing masks, and these people are getting affected much quicker, much sooner, and there's a higher load and a higher burden of people. And that's why at this point in time, we're seeing the epicenter in Gauteng. So that's the difference to overseas. And I think that's why our numbers are screaming up in Gauteng. And I see that's why in South Africa, we've hit number 10 in the world odometer sort of readings of this whole virus.
Mm-hmm. And of course, we're seeing close to or more than 13,000 new cases per day. And that was...
I think of those 13,000, there were about 6,000 in Gauteng yesterday. So the majority is coming out of Gauteng.
Right. In terms of prevention, a lot of conversation on the groups asking about taking baby aspirin, asking about which vitamins. And then there's a lot of talk as well about people using something like Pulmicort at home, cortisone, if they start to be symptomatic. Can you please take us through that? In fact, I saw an interview that somebody sent me with a doctor from Texas saying he's treating all of his patients, even very ill ones, with home, they're nebulizing at home, and he's seeing miraculous results. I don't know, I can't verify who he is, and I can see by your expression that you think it's absolute nonsense, but it's important for us to talk about these things because these are the things that are going on.
So, as I've stated before, vitamins are a very big part in this virus. We're talking about vitamin C, vitamin D, thiamine, niacin, calciferol. All those vitamins are very, very important. Zinc to help with the virus and help with the viremia. We've gone through the whole talk of hydroxychloroquine. At this point in time, it's being shunned. It's not working. We don't have any good beneficial studies showing that it works. You've got to be very careful about what we call prophylaxis and people taking so-called prophylaxis. Firstly, from a corticosteroid point of view, the dexamethasone study showed that it could help and probably does help with 30% of patients in hospital decreasing mortality. Now, those patients are in hospital, are on oxygen or are ventilated, and it's only 30%. We haven't had enough studies in this country to see what the actual dramatic effect of it is, but be under no illusions, it's not a cure. It definitely does help with our hyperinflammatory response, that third phase, and it's part of the mnemonic phase of the actual disease and of the virus, but it's not a cure. If you want to take things like baby aspirin or corticosteroids when you're in the respiratory phase, you're going to do yourself damage because this is a viremia. And if you take corticosteroids in the first phase of the viremia, you blunt your response of your body to react to this virus, and it could cause negative effects. So no one who's at home, who's not on oxygen sanctioned by their doctors, should be taking corticosteroids unless they are on chronic corticosteroids like an asthmatic or someone with rheumatoid arthritis and having an acute exacerbation, or if they've got emphysema. That's a completely different story. With regards to the blood clotting issue, and people are very worried about this, you shouldn't be taking injections or subcutaneous injections to prevent clotting, and you shouldn't be taking aspirin at all either. Aspirin works on the antiplatelet level in some effects, and sometimes people who get very ill drop their platelets. They get what we call a thrombocytopenia. So every sort of precautionary measure that you try and take to try and help yourself can actually bounce back on you and cause negative effects. And it's not going to benefit you to do these things. So you shouldn't be taking baby aspirin. You shouldn't be taking anticoagulation. You shouldn't be taking corticosteroids. And more important than that, the biggest problem, unless you've got a chronic issue.
You were taking it anyway.
100%. But more important than that is that nebulizing is completely taboo in this environment, whether you're at home, whether you're at hospital. A nebulizer is a high aerosol spreading of the virus. So if you are sick and you're positive and nobody else in your household is positive, and even if you've quarantined and they come close to you and you've got your nebulizer going, you are pushing out high virus particles. No one should be nebulizing. There are other ways to treat this. Your doctors can tell you exactly what to do. There are other mechanisms, other methods, but you should not be doing nebulization. We do not nebulize anybody in hospital with COVID-19.
There's a lot of concern as well from people that are chronic asthma sufferers. A lot of anxiety, understandably, from them wanting to prevent or just to remain as safe as possible. Should they be speaking to their pulmonologist about increasing some of their preventative medicine or chronic medicine, or if they are under control, they should just remain as is?
So we know asthma is one of the lower risks. The South African Thoracic Society came out with a statement saying asthma is a lower risk for COVID-19. However, if you are sick, then yes, you need to speak to your pulmonologist or your general practitioner, and they will give you the methods of what to do, how much of your inhaler to increase, or what you need to do, or if you need to go on to further medication in order to help you with the condition.
A lot of questions as well about reinfection. We asked this question last week, but I do want to talk about it as well. There are a couple of things. I want to move on to reinfection. I want to talk about quarantine because Professor Karim made a statement over the weekend or just a little bit before that seemed to suggest that quarantine periods are going down. So let's just talk about two things. Firstly, People that have been COVID positive, that have now fully recovered, are they free to socialize with people that have not yet had COVID safely?
The answer is definitely not. And there's many reasons for that. First of all, we know that we're saying to people, you get 14 days of quarantine with no symptoms towards the end, and then you're able to go back into the workforce. That doesn't mean that you're immune from passing some virus to people. But if you're wearing your masks and you're doing your hand hygiene and you're doing your social distancing, you will not pass any virus to anybody. The amount of virus being shed after that stage is extremely minimal, and it's unlikely that you'll cause any damage to people. But once again, we're still dealing with a novel virus. And if you think that you're immune because you've had the disease, you've got something else to think about, because only now are the South African sort of private practitioners relations acts bringing out all these antibody tests, and they haven't allowed any of them out just yet. But we still don't know what a person's reaction is going to be to an antibody test, what it means if you do have antibodies, and how long those antibodies last. So I speak about this often, but you don't have a passport immunity if you've had the virus. It doesn't mean you can't get the virus again. You know, someone who's asymptomatic and who's had the virus, and then 4 weeks later they get sick, it doesn't necessarily mean they've been reinfected. It means it's most likely a false positive the first time, and this time when they're sick again, they've been infected properly, and that's why they're having the manifestations. We don't believe you can be reinfected, but we don't know how much damage you can do to people who are not infected afterwards, and that's why we can't give carte blanche to people to go out and just go and visit people if you've had the virus. With regards to the second thing, with regards to Prof. Karim, I think that this was taken out of text, and I think that what he meant to say was that this was meant for healthcare workers. This is not for the general public. And I think he's going to clarify this in the next few days. For healthcare workers, there's a major, major depletion of healthcare workers at the moment due to doctors, nurses, allied health workers getting sick. If we don't have doctors, nurses, allied health workers to help people and to treat people, then we're going to be in a major, major calamity. So what they're saying for doctors who have been treated or have gotten the positive result, that after 8 days, you can go back into society and work in your full PPE, which is your full protective equipment, work with patients again, because it's unlikely you'll be spreading any viral load when you're wearing full PPE. And if you've had a query exposure, then after 5 days as a medical healthcare worker, you can go back into society. This doesn't allay, and it's not anywhere internationally recognized that this allays to any of the people who are laymen, who are working not in a hospital environment. So this is for healthcare workers. And I think it needs to be clarified, and I do believe it will be clarified by the Department of Health shortly.
And don't forget, there's also been a notification that President Cyril Ramaphosa will be addressing the nation tonight, and we'll obviously see what he has to report. I certainly am hoping that he's not going to a full lockdown again. I don't believe personally that it's helpful. I think that we all need to be responsible, but that's just my view on it.
Look, I'll tell you, I think people are scared. Okay, people realize this virus is now real. It's taken a long time. Unfortunately, people have to see other people getting sick. So I think people now are starting to take responsibility, but need to take more responsibility. So I'm not looking forward to his talk tonight, because they've let us down. The government has let us down for the last few weeks. So I'm not quite sure what they're going to promise us tonight or give us tonight, but let's wait and see.
I just want to go back to the medicine just for a moment. A lot of questions around taking Microdol. Originally, we were told no anti-inflammatories. If somebody needs an anti-inflammatory, are they able to take it, or are they putting themselves at risk?
So I think that's something that you need to discuss with your healthcare worker. We know that the original study was done by the French and said you shouldn't take anti-inflammatories. But we also know that in certain criteria or certain conditions, you can take an anti-inflammatory, but you need to discuss it with your healthcare worker to see if you've got any contraindications to taking it and if it's beneficial for you, or there's something else you should rather take.
All right, let's just talk about the signs of COVID. A few people have asked about COVID toe, about chilblains, about, and I hadn't heard this, that a sty could also be an indicator. What are the most common things that you are seeing? When does one need to speak to a medical professional and find out whether they should go for a test or not?
So the most important is if you are symptomatic. I don't consider a sty or a chilblain or painful toe or painful red swollen toes a reason to go for a test, and that's not being considered symptomatic. These have been found in certain cases, and we know that the dermatologists have found them and shown them that they do coexist with COVID in certain cases, but not every single case. However, if you have got a fever, if you're short of breath, if you are coughing, if you lose your sense of smell, if you lose your sense of taste, if you've got abdominal complaints with diarrhea, and having a multiple of these complaints and these symptoms together, then you need to go for a test. With one isolated symptom, let's say you've only got a loss of smell, you don't need to go for a test. But if you are suspecting or you've been in contact or someone around you's had it, then rather just isolate yourself or quarantine yourself for 14 days. A test is not going to help you in any way, and if you don't get terribly ill, unless you say to you, yes, I've had it, but you're still going to need to isolate or quarantine yourself.
And just for clarification, you consistently recommending, in order to check for the smell and taste, a single malt, swirl it around, smell it, taste it. If you do that every day, at least twice a day, you'll be very clear on whether that your sense of smell is swirled.
I think that's paramount to actually deciding whether or not you'll be able to go forward in life. One single malt, a two-finger tot without ice. That's the way to go.
Right, all right. But and just as a disclaimer, that you didn't really mean that. Okay, where are we with trials around vaccines? I know that South Africa is participating through VITS. Any feedback on that?
So that's with Cambridge, and that's from overseas in Oxford. They're all collaborating, and they're working on an adenovirus type of vaccine. They've got about 2,000 volunteers that have to fulfill certain criteria to be part of this vaccine. And this is going to take a while. This is not going to happen overnight. All over the world, people are racing, and we've got very clever people, scientists, epidemiologists, medical professionals. People are racing to try to find a vaccine. As of yet, we are nowhere closer to it, but people are trying extremely hard to try and get to be the first one to make the vaccine.
All right. Just talking now a little bit about general care. Somebody saying that I'm very, very careful around work. I wear my mask at work, obviously an Orthodox Jew. He says, but I come home, as I walk through the door, I shower, my clothes go straight into the wash, but I realized that that every day I wear the same kippah and I wear the same shoes a few days in a row. Is that a problem? Do I need to even be careful about that?
So it may sound like a silly question, but it's actually a very good question. And myself personally, when I come to the wards, I change my kippah. And when I come and leave the hospital, I change my kippah, I change my shoes. I think it's very important that. I think that you know that the same way that you're changing your clothes, you should be changing something like that as well, because that's also something that can harbor a virus on it. And you don't know if you're touching your mouth, you're touching your head, you're touching all over. And as for shoes, you don't know if people have coughed and the virus has dropped onto your shoes. So rather leave them outside and rather change them and rather have it. It's not to drive people mad and say you've got to be paranoid. But if you are doing these things already, then just make it a bit more stringent and do them with a different type of twang.
So we are still very concerned about surfaces.
We still are concerned about surfaces and fomites. And you've got to be very careful as well, because as long as you're washing your hands all the time and you are doing the hand hygiene, it shouldn't be an issue. But we get lax, you forget, and that's human nature. And it's not because you don't want to do it, but because you walk around and you touch something, you come home, you go for a walk, and you forget. And by the time you've come home and it's 15, 20 minutes later, and then you go and sit down, and then 3 hours later you go, oh my gosh, I haven't washed my hands. That's where the damage comes from.
Because a few people actually asking about, and we've had this question a number of times, but it's worth reiterating. I get my groceries delivered, or I walk through the door. I've just been to the shop. Must I spray my groceries? Must I wash them down? How careful do I need to be?
Look, you must wash your hands. 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 If you are worried, then leave your groceries for a few hours, or don't touch them, or don't put on gloves if you've got a packet that you don't want to touch, and pour the stuff out, and then leave it just to stand there if it's not perishable. But you can't drive yourself mad about these things, because you're going to be living in this little bubble at the end of the day that you can't touch anything. And you've got to be realistic that certain things, if you just carry on maintaining the hygiene, that you'll be able to sort of overcome those type of things.
Tell me about those masks with a valve on the side. A number of people have them. Are they okay to use?
So those masks are fantastic from a comfort point of view, but they are not good for other people. But remember, the whole purpose of us wearing a mask is so we can protect other people. It's so that we're not selfish. If it's got a one-way valve, it means you're able to breathe out but not breathe in. So therefore, if you're breathing out, you're expelling your own droplets and your own sort of breath, and you're making a little bit of an aerosol there, which is coming out that can potentially affect other people. So they're not advisable, albeit they are very comfortable.
Okay, just talking about things like hairdressers have opened. I know a lot of the places are very, very careful. Somebody asking, if I am careful and my son wears a mask and the hairdresser wears a mask or the barber wears a mask and they sanitize, is it okay to take them for haircuts?
Look, we're in the eye of the storm. You know, we're seeing thousands of cases a day. We should be in a lockdown. Okay, we can't obviously be in a complete lockdown because of an economic point of view. But things like that are still considered dangerous, albeit that we've been allowed to go to them. You're still exposing yourself to other germs, to other surfaces. You know, you've got to be able to trust your hairdresser. And then it's a whole trust issue, first of all. And we don't essentially know what the spread is in these type of environments. Is the ventilation good? You know, are they cleaning it every half an hour or after every single patient? Are they using hypochloric acid? Are they using bleach? Are they using disinfectant? There's so many variables that could go wrong here. Yeah, so I'd say rather not. Yeah.
Extramural activities for kids?
At the moment, no. You know, kids, if they go to school and come home and stay at home, no play dates, no social action, no extramurals for kids.
Quite a few questions about defogging. I know a number of officers have defogged. Somebody's saying if somebody in the household had COVID, they've now recovered, is it worth defogging the house?
Okay, so the term is fogging, okay? And it's important to know it's called a fogging. It's a fogging procedure, okay, where you fog with certain chemicals.
They need to rebrand that. They need to remarket it.
So if you've had COVID and you want to sort of clean your house, so first of all, answer this question. Who are you fogging the house for if you've all had COVID in the house? You're not having people at your house. You don't need to then fog your house, okay? You need to clean the surfaces, which you can clean with bleach or you would clean with other active agents. In a work area, it's a completely different situation because there are people in and out the whole time. So in a work area, if there's someone who's been positive, or in a school area, if there's someone who's been positive, you should ideally fog, but fogging is very expensive. Or what you can do is leave the area for 24 hours after a thorough clean. So once it's been cleaned thoroughly on all the surfaces, you can leave it for 24 hours and then that's okay as well.
A few people asking about domestic workers. You've spoken about that before. Somebody says they want to employ a new domestic worker who will be live-in. What is the protocol?
So in order to be safe for your domestic worker and for yourself, and if they live in, let them stay at the area for 2 weeks before you or them are exposed. And as long as they're symptom-free, there shouldn't be any issues.
Okay. And a few people asking who you see in the hospital. Who are the people that are being admitted to hospital? Who are the ones, are you seeing a trend of people that are suffering very badly?
So the trend we're seeing is obviously the elder people, but the bigger trend is the people with multiple comorbidities, not one comorbidity. We're talking about diabetes, hypertension, collectively with obesity, people who have got multiple comorbidities that are coming in and are very sick. This is the trend we're seeing at the moment. These are the people that are getting sicker. Doesn't mean to say that if you've got one comorbidity, you can't get sick, but it's less likely that you'll land up in hospital as the trend is that we're seeing.
And just for clarification, hypochondria is not a comorbidity.
I actually refuse to answer that.
All right, fine. So I'll have to ask some of the other doctors I have on speed dial as well. Finally, asymptomatic transmission. Has there been any further progress on this in understanding if asymptomatic people can transmit the disease?
Asymptomatic people can definitely transmit the disease. We know that. And that's why if you are asymptomatic, you still have to quarantine for 14 days. There's no doubt in our minds. This is evident. We've seen it. It does happen. And this is a big worry because a lot of people get sick without being exposed to somebody who's ill. And this is from asymptomatic people.
Or I'm sorry, I lied. There is one more question that I want to ask, and that is around preschoolers. Quite a few people asking for you to clarify what you said last week on the Sunday Synthesis podcast.
Look, I think you've got to be very careful, okay? You know, we know that the schools are doing brilliant jobs looking after the children, and they can manage the children because the children are responsible and they understand what it means to wear a mask. They understand what social distancing is. When it comes to 3-year-olds and 4-year-olds, it becomes much more tricky, okay? Because the 3-year-olds and 4-year-olds don't understand it, and they can't wear their masks for long periods, and they are far more needy. So if they fall, if they cut their leg, they're going to need the helper to come and help them, to pick them up, to help them with these type of things. They're going to have runny noses. We're in winter. There's influenza going to come around. There's other viruses that are going to come around. They're going to get sick. So you've got to be very careful with that type of situation. It's not as simple as sending a 5, 6, 7-year-old to school who's got an understanding and who's able to actually co-manage themselves.
All right. Thank you. Is there any good news?
So I think there is very good news. And I think this has been a very serious discussion today. And I think we've got to understand that we're not speaking about the majority of people. The majority of people, more than 85% of people who will get the virus will be okay. Albeit you might have fatigue, extreme tiredness, bit of muscle pain, and it might feel like you've run a marathon without actually doing anything. You will be okay. 85% of the population will be more than okay. 10% of the population will get ill, and only 5% will be critically ill. And I think we've got to realize it's 85%. It's a majority of the people. And that's why you can't be paranoid to the fact that if you do get symptoms, something is going to go wrong. You've got to look after yourself. You've got to stay well. You've got to look after all the social norms. I think what's important to say is that we will carry on with this fight. We can lose every battle except for the last one. And with that, I need you to keep looking after yourselves. Stay safe, wear your masks, wash your hands, and know that you are most likely going to be part of that 85% and you will be okay.
Dr. Anton Meyberg, thank you for all the work that you're doing. I know the strain, and I know how difficult it was to even carve out this 45 minutes or however long it is that we record for. We all are deeply grateful to you and everybody else in the front lines, doctors, nurses, pharmacists, emergency first responders, everybody doing an absolutely phenomenal job. I'm Howard Feldman. This is the Synthesis Sunday podcast, chatting to Dr. Anton Meyberg. Please make sure to subscribe below so that you are ensured that you will receive these podcasts or notification around these podcasts when they become available. Have a great day, have a great week, and just be safe.